Thank you, Barry, and welcome to everyone. I'd like to welcome our next speaker. It's Brad Gelbart. He's a orthopedic surgeon both in private and hospital practice, and he's going to talk to us about back to surgery after COVID-19. Brad, all over to you. Thank you.
Thanks, Prof, and thanks, Professor Jacobson, for inviting me to speak, and to Sandoz, our sponsors. This is a very long talk, so I'm going to run through it as efficiently as possible, trying to do it justice. There's lots of research out there. It's quite novel, so bear with me. There are lots of slides, but just listen rather than try and read everything. I call it Back to the Future because we've kind of taken a knock, and we're trying to get back to where we were many years, a year ago, and I think it's not going to happen for a while. My disclosure is one, I'm an orthopedic surgeon, so assessing literature is often a challenge for us, but we'll try and get through that. And there's no royalties or fees in preparation of this presentation. A quick tribute to all the healthcare workers and administrators and everyone dealing with COVID around the world. And in no way do I mean to minimize what they're doing. This is a novel virus, which means it's new. We're still learning. We are getting more experts now. We certainly need the value of hindsight, but we don't have that at the moment. I believe in holistic evidence-based medicine. And today I'm just going to focus on the risks to the patients, not the healthcare workers, nor anyone else involved in COVID at this point in time. And really the objective was shown in this study, where it said that patients in the time of COVID are being deprived of surgical access with uncertain loss of function and risk of adverse prognosis. And we need to make a contingency plan on how to maintain care in the ongoing phase. Now, it's a few basic principles we need to see. The first one is the case fatality rate. And this is South Africa's figures by one of our biggest insurers, which shows the highest mortality in the 70 to 90 group. But even those between 70 and 90, about 80% still only have mild and moderate disease. So not everyone's dying of this disease. This is an updated graph. And if you look over here, South Africa is red. We're down here at the moment on a daily confirmed cases per million. If you look at the United Kingdom, United States, and Italy, they're way above their peak from early on in the year. So this disease is not going away anytime soon. But interestingly enough, look at the case fatality rates, which are significantly improved, even with the increasing numbers of cases. And I'm not sure why that is. Better treatment, better utilization of resources, we understand more, but less people are dying than those first few pictures of Italy, where everyone is in the streets on their hospital beds. And then maybe that might also help us affect our decision-making going forward and utilization of resources. Just some very quick graphs on the predictability of COVID from early on in the year. These are some countries around the world. This is South Africa in August and all the countries around it. And which curve do you think anyone can be on? Anywhere? No one knows. So we have to get back to doing what we're going to do and treating patients as best as possible. COVID testing, as you all know, this is what surgeons need to know. What we need to know is that it's not perfect. The lab people will tell you sensitivity, specificities, but every COVID test's got false negatives, false positives, and it's not a perfect system either. So where did this all start? Well, it started in China, we believe. And this first paper in March was really something that scared the surgeons around the world, because it came out and said, if you have COVID and you have surgery, you've got a 20.5% mortality rate. And that was extrapolated to all surgery. And that scared the living daylights out of most surgeons and most hospital groups. But if you look really and go into that study, look at the cases that were done. Whipples, thoracoscopic lobectomies on old patients. This wasn't a heterogeneous group of young patients as well going for elective surgery. And so maybe we were a little bit scared at the beginning. We had to start looking at better data. COVID surge, got a bigger group together, 1,128 patients. They still had a mortality rate of 23%, but also all comers. What they showed was an increased mortality rate in males, the weaker sex, age 70 years or older, ASA 3 to 5, the high-risk patients anyway, malignant versus benign disease, emergency versus elective surgery, and major versus minor surgery. In other words, anybody who would have had a worse outcome is at higher risk. Now you're just adding on an additional insult to the body. So that makes sense. So we orthopods, we like to do things and look for more specific trials. And one thing that had to go on during COVID was old people fractured their hips. And in the UK, lots of people fracture their hips. It's a great cohort to study. And there's a few excellent studies that were done through the COVID pandemic, the early part in the UK. I'm sure it's going to be interesting to see what comes out now. The first one was looking at the independent influence of COVID-19 on 30-day mortality in hip fractures. Unfortunately, they showed that if you had COVID positive, your mortality increased. Once again, another insult on top of an already insulted patient. But what they showed was that even if you got it in a rehab period later on, you still were in trouble. So was the mortality related to the fracture, the COVID, the combination, or just all your other risk factors? So further study was required. This study looked at this similar group, but compared the mortality to the 2019 cohort. This was a bigger group, 76 patients in both groups, and they showed that there was no increased mortality pre-COVID to COVID, 13% versus 14%. Maybe their COVID patients did better because they had more regional anesthesia, which has been shown to improve outcomes. I don't know. But interesting facts, not quite increased mortality. So they started asking questions. Interestingly enough, most of their patients were transferred to rehab at 9 days and may have picked up COVID there. Their mean time to COVID from the surgery was 16 days, and many were likely infected in hospital. Let's keep that in mind. Orthopedic trauma, a bigger group, 496 patients. Again, no significantly increased mortality in those with ASA 1 or 2, but 3 to 5 or greater than 75, high risk of death. But interestingly enough, in elective surgery, the bread and butter for most people, there were no deaths, no increased mortality, and all of those increased mortality were in those emergency cases. Again, what COVID surge showed. But if you look at the ones that died, look at their age group and look at their comorbidities. So just so on an unpredictable virus, and it explains a lot. So if you are going to go and introduce elective surgeries and operate on these cases, you need to look at the individual patient risk profile. I'm going to skip through these studies very quickly. In vascular surgery, similar, cancer surgery, in France, across the channel, same. And so how do we restart surgery and how do we do surgery in a pandemic? Really, the first thing is, do patients want to have surgery? Well, the truth is that most people just didn't want to have surgery, never mind if you could do surgery. They were just scared. Whatever the media, the thoughts of problems, they didn't want to come for surgery, so already they selected out. But if they did want surgery, well, it was found that if you've had a green COVID-free hospital or a COVID-free unit or a place where there was no COVID patients, your surgeons did well. Your surgeons did well because they were great, and your patients did well because they didn't contract COVID. And this was shown across the UK as well, where a COVID-free model was a safe and effective way. Often you have to have it in one hospital. You can't have separate hospitals, but if you are able to have a green hospital, even better. The value of testing preoperatively is important. And if you get a negative test preoperatively, the global risk of death, which is what they show over here, in elective surgery is 1 in 140,000, which again puts most people at risk when they hear those figures. There are lots of stats in that article. You're welcome to go and have a look at it sometime. The testing guidelines continue to change. Currently, we test 3 days before admission to hospital. But when you're in the middle of the pandemic, symptom onset is also a concern. And so we need to take that into consideration. I'm going to run through these quickly because these change all the time. Antibodies may or may not have a role as we get through the pandemic and more people get antibodies. But finally, the clinical considerations. For those who've had COVID, they're at risk for cardiomyopathies, pulmonary fibrosis, and certainly during COVID, coagulopathies. And these are a big risk for surgery and bigger surgeries, and something that we shouldn't put aside. And unfortunately, most of these complications do go on for longer after the actual acute disease has recovered. So in conclusion, Mr. Chairman, COVID-19 is real, still unpredictable. We're going to have to learn to live with this for the foreseeable future. If you contract COVID perioperatively, your risk of mortality and morbidity is equivalent to a community-acquired disease. Provided we take adequate precautions, I think we can safely continue to practice the rest of medicine and surgery, and should. Perioperative PCR should be mandatory for all surgical patients. The shortest hospital stays possible should be encouraged, 8 days or less. And COVID-free hospitals and units should be created. Thank you very much.
Thank you, Brad, for keeping to time. And there is, I think, a couple of minutes that we have for questions. If there's any questions, please raise your hand or go into the chat. But there is a question and answer area. There is one I'm seeing, but I think that is for Dr. Lowe.
So if we've got time to discuss, Prof, while the questions are coming up, I think it's very important to understand, and we are currently in South Africa are on the bottom of our curve and in a good place. And therefore, our patients are far more comfortable to come to surgery. But I think when we get back into the next wave, and as you can see is happening in Europe now, the challenges will be real. And I look forward to the research coming out from this to see what can and can't be done. And now that our mortality rates are improving worldwide, I think we're going to be in a better place with more positive people. And really,
so can I ask you, Brad, so if a patient comes in now, would you recommend that they have elective, so someone who's been waiting for a knee replacement, for example, would you recommend that that's an optimum time now to do it? Or would you, I mean, should we do it now before we hit a second wave? What is your recommendation when someone comes in for elective knee? I mean, you're a famous knee surgeon, so someone comes to have their knee replaced and you need to pay for your holiday at the end of the year. Do you think we should be recommending knee surgery currently, elective knee surgery, for example, a knee replacement in the last 30 seconds? What would you recommend?
Like I said, your risk is related to your prevalence in your community. And our prevalence in South Africa at the moment is extremely low, which is why I showed that graph. So my answer is absolutely. We should be doing as much surgery, elective surgery as we can now, because when we get to the numbers in Europe and where they are, we're going to have to possibly slow down again. And so if you've been waiting for your surgery, now it's time to do it.
So as long as you're not in the Eastern Cape. So if you were in the Eastern Cape, you wouldn't recommend it because their numbers are going through the roof. So I mean, that's the question, because it seems to be quite a dynamic changing thing. But I agree with you now. So I'm referring my patients now currently for elective surgery. Those people that have been waiting, I've been telling them now is a good time to go and do it before we hit the problems that are hitting Europe. So I think that might be my advice. I don't know if it's correct or not, but that's what I've been. What do you feel, Talib?
I think I agree with Brad. We should do it. Go ahead, take all the precautions, obviously, and go ahead with the surgery, because we are compromising a lot of these patients, as that British study showed. A lot of patients awaiting elective surgery. We should go ahead and do them. I mean, from my side, I've got patients who've got chronic limb-threatening ischemia who require surgery. And if we delay them longer, instead of going to a below knee, they go to an above knee, for example. So yes, we should do it in this window period. Thanks.
Thanks very much. And I'd like to also acknowledge Sandoz, who were the sponsors for Dr. Brad Gelbart's talk. And thank you, Brad, very much.